Tumesign sheria juzi, tunamaliza regulation in the next 1 month. Kufikia Januari, sasa tutaanza program, kila mtu apate card ya hospitali. Ni mnanielewa? Kila mtu apate card ya hospitali. Either utakuwa umelipia shilingi 300, ama serikali itakuwa imekulipia, ama kama mimi na hawa wadosi hawa, malipo yetu itakuwa juu kidogo. Na tujasema iende juu sana, hapana, tulipe to the same percentage. Mama mboga yaga ni 2.7%, hata mimi 2.7%.
So that is the president speaking yesterday, just a few days after signing into law the 4 health laws. Let me begin with you, Honorable Mathenge, because you sit at the Health Committee. So if you peruse all those laws, especially the one on Social Health Insurance Act, yes, it talks about there shall be contributions from different personalities. So if you're employed, then it's monthly. If you're not employed and you have an income, then it's annual. If you're unable, then the government is going to make an allocation through Parliament. If you're in prison, then the government is going to take care of that. But the president is already speaking about some percentage of 2.75%, and there has been a lot of backlash, both from members of Parliament, but also the Ministry of Health, that there's no such a figure that you purport to have. So what are you supposed to believe the rate of contribution to be?
The rate of the contribution in the law is 2.7%.
I didn't see it in the Act.
In the
regulation.
You see, what happens is that once the law has been done, to activate the law, we have regulations that come in place.
Right.
In the course of lawmaking, figures for funding healthcare, UHC, actuarial scientists have presented different scenarios with different figures. And therefore, in the health sector, including health financing experts, the different scenarios for sourcing of funding have been factored in. The thinking, the dominant thinking in the health sector, and from health experts and from insurance experts and actuarial scientists predicting the consumption, then the contribution from salaried workers has been capped at 2.7%. But even at 2.7%, the different scenarios emerging so that the Social Health Insurance Fund should not be returning profits. The scenario worked out has shown that the requirement for 2.7% brings uniformity across all sectors and coherence. However, once you hit the maximum contribution of 5%, then it will be capped at that level for higher wage earners. The reason why it is put in regulation is because the regulations are easier to amend or change to respond to emerging situations, rather than when we put it in law. And when it is fixed in law, we have to go through an entire new process of amending the law through the legislature, which is not an easy process, and it takes quite some time, even when we try to fast-track it.
You just lost me there. You said that 2.7%, but when it gets to 5%, you cap it. What is
no,
that?
When it gets to 5,000. So for every salaried Kenyan, the maximum you will contribute from your salary, even when your salary is computed and your 2.7% is higher than 5,000, you will only pay the maximum of 5,000.
So, for instance, the president has a salary of about 1.4 million shillings.
Yes.
2.75% is way above 30,000.
Yes.
So he will not have to pay 30,000.
No, he will pay 5,000.
That was our push. That maybe I just jump in there. Initially, by the way, that was the implication that any person with wages above a certain amount would start paying almost that kind of a lot of money. So as the association, we said we are using a bottom-up approach, whereby we are looking at this person who, in quotes, and probably I would ask Nelson we start moving away from us against them. You see, sometimes when you say those who are earning higher, you get a perception that that person is different from someone else. Yeah. So I think politicians probably, just to help, stop categorizing people. I'll use myself as an example. I have a salary which I pay as a civil servant. My percentage would probably be about 6% currently. It was designed such that my medical cover was given to NHIF in 2011, plus I pay $1,700 every month. So it comes to about $6,700 per month. And hence you saw those different categories, like civil servants were said, oh, they look like they're being treated better than others. In an insurance model, it's actually because they're paying more. If you multiply 6,700 by 12, that is a private medical cover, literally. But that was because the previous administration moved the medical, so I don't get a medical allowance, but the medical allowance was given to NHIF. Secondly, those people who are even earning higher are also paying NHIF for their relatives. Like, I pay relatives for my parents. I pay relatives for my brother who has, maybe the money he earns is not enough. So you see, so that categorization that those who are earning higher is actually not sort of a true reflection, and now it hurts them more. Right. And then when you include one more thing, which is that the salaries have not increased. I have not had a salary increase from the year 2011, but my expenses have increased. The fuel has gone up 100%. The deductions that are coming have gone up. So in net effect is that we are poorer but paying more. So it becomes, I think that's what we really need. And I'm very happy. I heard the CS, Susan Nakumincha, mentioning that this cap of 5,000, which is what the Kenya Medical Association had actually called for, is actually being put. And it makes sense because Mheshimiwa here has also other expenses to make. He has constituents to contribute to, funerals to. If you now tax him under the guise that you will pay health care for him, right, he may not be able to meet his other needs.
Interesting. Because, Honorable Koech, when you speak to different people that would know, they tell you that there's a contest whether it should be capped or it should be a flat rate, just like, not flat, but 2.75% applying to the salaries, just like what is happening to the housing levy. Remember earlier on there was a cap of maximum 5,000, but ultimately what was passed is 1.5% of your gross pay. So how do we know for sure that there will be that cap, knowing that the president is speaking ahead of the regulations?
First of all, what we must appreciate, and I think this is something that we need to mention, this is a game changer, Sam. It has shaken up the entire health sector in this country, the entire health sector space. It is revolutionary. The indignity that Kenyans suffer, people being auctioned because they cannot afford Medicare, emergency medical attention by medical facilities, people being turned away when they're on their deathbed. The contributions we make, even as my colleagues here, members of parliament, even you people here in the room, every single day you receive distress messages from either family, friends, or, you know, or even the community asking for support. This will change that scenario. And this is the Kenya Kwanza manifesto. I really want to thank the president because these were the stakeholders forum that we did before the elections and after. And these are some, and the figures have come out. Like Honorable Madenga is saying, there are accurists who have actually developed this plan and have come out with 2.75, matching, and a matching figure also from the employer, to make sure that people, we use universal healthcare. I'll use the example of the UK, if you may. In the UK, every employee pays 4.5% of their salary to the National Hospital Fund, NHS.
NHF.
NHS, they call it NHS.
Sorry.
That one has allowed, it's actually one of the best models in the world, has allowed everyone to access Medicare, from treatment of cancer, attention, emergency medical attentions, shorter times to access, improved medical facilities, even in hospitals, so that we have CT scans, we have all these necessary x-rays. And this is the time now that we should think as a country, how much money does this country spend in sending sick patients to India?
How many do we spend in sending patients traveling from Kenya to other countries to seek medical attention? I think the president and the Kenya Kwanza administration and the members of parliament must be lauded for this move of passing this Social Health Insurance Fund Act to make sure that Kenyans can access Medicare. 2.75%. Or 5,000 for that matter, for me as a member of parliament, is not a big ask. Let us be very fair. Let us afford everyone the dignity. Not everyone in this country is employed. Those of us who have had the opportunity to get into employment, it's not that we are special in any way. It is only that God has granted us favor and we're in those positions. We should take responsibility to make sure that those facilities are improved and it is able to meet the demands of this country. I totally support it. It was launched in my county during Mashujaa Day. You should have seen how people were very enthusiastic about this scheme. It will be a game changer. I think I also get your concern that you think these resources will be prudently used now that we deduct. And number two, I think your worry also, Sam, is the percentage that is going to be used. The people who should be complaining, and I've seen many people are complaining who are not even employed. The people who should be making this noise are the people employed. Daktari here has a clear picture, in fact, of the camera, and he's still calculating for me why he thinks this scheme is a game changer. We've repleted National Hospital Insurance Fund. People should know that. We are not talking about National Hospital Insurance Fund. That one in law now is out of the question. What we are dealing on now is the Social Health Insurance Fund, which has Primary Health Care Act, Facility Improvement Act, Social Health Insurance Act, and Digital Health Act. It's perfect, it's a game changer, and Kenyans should be very, very excited of this achievement.
Okay, so again, the clip we listened to from the president was talking about tumesema tulipe percentage 2.7%. I don't know whether it's 2.7 or 2.75.
2.75.
2.75%,
Yeah.
but also says that 2.75% ya milioni moja si munaona iko juu ya 500 ya mama mboga. So it is not clear, and the reason why I'm asking this question is because we've been here before when we were having the conversation about the Finance Bill of 2023, now Act, and there are all these figures with caps, eventually without. Now we are talking about regulations that not even exist.
Sam, can I say something before you give it to Robert, just to clear that doubt?
Yeah.
Like Dr. Ari said, these regulations, the CS Health is going to gazette the regulation.
Correct.
After the gazettement of regulations, after gazettement, the CS now and the regulations therein will provide a clear framework on how it will be implemented.
And that is what I'm saying, because Honorable Mbui here we are speaking, and we've been told there's a cap here of 5,000 shillings. The president is speaking, or it will appear like it's 2.75% of whatever the amount it is. So how will all this be translated to the regulations? Yet the cabinet secretary takes instructions from the appointing authority, who is already speaking about a rate without a cap.
Sam, thank you. First and foremost, Sam, I want to point out that the law doesn't have that figure.
Yeah.
In fact, what the law says is that the CS of Health will from time to time set the rates that are payable. So it's actually a blanket check. I mean, they can say it's 10%, 20%, anytime. So, but they've been slowly pushing the narrative that they'll put it at 2.75, and I believe maybe that's what they intend to do. But the interesting thing about this regime is constantly talking about what will be done and complete disregard of one very important partner in management of the country called Parliament, where my two colleagues sit. The executive actually talks about what will happen in Parliament before it happens. That just tells Kenyans that Parliament isn't independent anymore. Because when it comes to setting those figures, it should be this House, Parliament. It is the three of us and others who should be sitting and asking ourselves and listening to the experts and making a decision. But the executive makes a decision, pushes it down our throats, and members will be cheering and saying, oh, you know, we were in Kericho, it was exciting, it was marvelous, everybody was excited, there was a lot of rains, their boots were muddy, and I'm wondering, how is it really a positive? I want to say that Kenyans are already highly taxed. And Honorable Nelson Koech has been very categorical here. He said, you know, I think the percentage in the UK, he said, was like 4%. You know, Sam, you cannot compare the average Kenyan earner with the average UK earner. You know, you can't compare. It's like apples and oranges. Why do we keep forgetting that? Why do we keep forgetting where we are coming from? Because we keep talking about these percentages. Oh, you know, in this country they're paying this percentage. But if somebody, assuming, I don't know the exact average earnings in the UK, but I know they're way above what we are earning. So 4% of an earner there may not hurt them as much as 4% of a Kenyan will hurt a Kenyan. So 2.7% for me already is quite high because, and I'm happy because I saw the Standard has already pointed out the ways by which Kenyans are already being hit hard. You know, the cost of almost all our basic commodities has gone up. Cost of fuel has gone up, affecting everything. Cost of food is high. Cost of travel is high. So already we have a major problem. Of course, cost of university education is still uncertain, but from the figures that parents were given is high. So already we are dealing with the high cost of living. And our disposable income, as Daktari has said, is becoming less every day. Already we've introduced the housing levy, and some I'm very, very bitter about this housing levy from those days. And now I'm even more annoyed considering that there are people in my county, about 10,000 families whose houses were brought down, and these people have loans, mortgages, and they're still paying housing levy. They had their own house, it's brought down, and they still continue to pay housing levy. So the thing is, Kenyans' pockets have been raided by Kenya Kwanza, and Kenya Kwanza has to give us some space. We said, you know, you've already raided us enough. Why don't you allow us to move on from where we are? So basically, I think for me, the president should not jump the gun. He shouldn't be talking about the percentages. Let those regulations come to the House. Let members of parliament, for once, you know, debate these things soberly and ask themselves, are those hustlers in Kericho capable of paying this extra burden? Daktari says he's having a problem. He's paying for family and friends. We are paying for constituents. We are supporting people. So even when you are saying it's little, remember there are people who are also carrying a big burden because the unemployment problem in Kenya is quite major. So for me, on that particular part, I think the president should allow parliament to work. But this bill, basically, I think it's not a bad idea. And we had canvassed similar discussion, even in the last parliament. We had discussed a similar bill and talking about making sure that everybody is brought into the bandwagon to make a payment. Those who cannot, they were being called indigents. The government was to pay for them, which is a good idea. So that everybody has a medical card. Because universal health care is important for all of us. Azimio had it as a manifesto. Jubilee had it as a manifesto. Of course, Kenya Kwanza also have it as a manifesto. But how do we go about it? I have one or two issues with this. The categorization of the different ailments and problems which is in that bill, I accept that and I think it makes a lot of sense. But I have a problem when SHIF proposes that after 1 year, every employee of the National Housing Hospital Insurance Fund will be rendered I don't get the English word, but basically jobless. No.
That is not correct.
What is happening is that they have been given, you've been given, I think, a period of a year or something like that, so that you could, within that year, that's a transition period. Then after that, these people will be given opportunity to reapply. Some basically, I'll tell you, if they're not shareholders, they will not get those jobs. So basically, 1 year from now, some of these people are losing their jobs. The other issue I have with this bill is a management of payments. You know, insurance basically deals with claims. And the proposal is that we give the claim function of SHIF to private players, so that it is not SHIF that is dealing with the claims. They outsource it. You know, it's like this. You set up a school, then you outsource the tuition. What are you doing? I mean, you cannot, you set up a hospital, then you outsource treatment. SHIF basic responsibility should be managing the claims of their clients so they can ensure that if you're making a claim, it is legitimate and then payments are made. But the government of the day believes that Kenyans who work for National Housing Insurance Fund and the ones they'll employ at SHIF will be corrupt, but the people in the private sector are not corrupt. So basically all the payments will be handled by an outsider. And I think that's
when the law says made, does it give any solace?
Now, let me tell you some. You know, the minute you see a loophole, the minute you see a mention of, why would they need to say that? Because the law doesn't stop you from doing some things through using experts. No law stops you from using experts. If your responsibility is to manage claims, you could, maybe, consult with other people at a point here and every now and then. But when you put that in the law, that means that is the intention. The reason why it found itself, why is it not in the National National Hospital Insurance Fund? It is in the Social Health Insurance Fund. The truth is that the intention is to outsource the payments. And what it means is that there will be people making money out of those payments. And the people that will get those contracts, believe you me, it is the who is who.
Now, you
Yes.
do not agree that the employees of NHIF will be jobless at the coming into effect of the authority?
Sam,
Yeah.
the trend in this country has been that whenever a new entity has been created, the employees who were in the predecessing entity automatically transited. There was no suitability assessment. And we felt that that is not appropriate, and there is a need to change direction. And this is what the Act has said, that the NHIF, as we know it today, will exist for 1 year in a transition period.
Right.
As Dr. here had said, there are a lot of facilities, hospitals that are still owed money by the current NHIF. NHIF has to be resourced enough to transit and clear some of those engagements that are there. Then secondly, the question of suitability. Remember what we said here, that with the now absent El Nino, there's a question of how fit for use is our meteorological department. The same question applies to the current structure of NHIF today. How fit for use are not just the employees, including the board. And there are 3 options. One, when the new board of the Social Health Insurance Fund is in place, the current employees of NHIF who have the requisite skills, academic papers, and experiences are eligible to apply. Number 2, those who will not be absorbed will be redistributed within the public service. And then number 3, those who do not therefore want to be redistributed and have not been absorbed have the option of taking an early retirement package. That is what the law says.
So,
there is
hold on, Honorable Madenke. You said that you appear to suggest the NHIF is not fit for purpose as currently is.
Yes.
Is the problem the manpower or the resourcing?
Manpower, resourcing, systems, oversight. The 4 of them. In NHIF, we have people who do not have the requisite papers doing jobs beyond their skills and competencies. Let me give you an example. The Quality Assurance Department within NHIF that is supposed to verify every claim and treatment that Daktari gives to an NHIF client and therefore originates a claim. There is no way a clinical officer or a nurse can be able to authenticate a surgical procedure. Their training is not at that level. So why would I want to transit those quality assurance officers to the new body? And that is the biggest area of abuse where fake claims are being processed and paid by NHIF.
Yes.
So is it possible to bring a qualified person and still process fake claims?
And that is why I have said, it's not just, I've said there is a human resource, there is the financial resource, there is the system, and there is the oversight. I have cited the 4 areas. That is a general area of weakness. Number 2, Honorable Bui, and he's my senior in Parliament, he knows very well that in the course of committee sittings, where a lot of the sector-specific businesses of the House are carried out, every member of Parliament who has an interest in a sitting of the Health Committee can come before the committee as a friend of the committee and participate in the deliberations. And therefore, this question of sitting there and wanting to point fingers, he is in parliament. He knows these things. He's actually my senior. He should be teaching me some of these things. If something is happening in agriculture and I have an interest, I can apply to the chairman to appear there and make a contribution. We have gone for very many meetings on these 4 laws. We've listened, we've interrogated, we've asked for the different scenarios to be presented before us. As parliamentarians, in the health committee, we are convinced we are on the right track. But we also understand that we may not get it perfect the very first time. It would be desirable, a lot of times it will not happen. But the law is a system in works. That is why we have regulations, so that any gaps that we could have seen in the main law can also be tightened in the regulations. After that, we have the window for amending the law as we go along. Sam, I had an amendment to the NHIF Act that was pending before the House to cushion the voluntary contributors that Daktari pays for, because those are the sector of Kenyans who have suffered most in the current NHIF. Some, those voluntary contributors pay their money in advance. Daktari, he pays his money at the end of the month, while he has already consumed services. These are the people, if Daktari's salary is late, and therefore his deductions get to NHIF late, which more than often happens, the voluntary contributor pays in advance, and should they default, they are penalized. Yet, they are largely confined to public hospitals where services are not available.
Okay. Daktari, because we've been mentioned, the Cabinet Secretary, Nakhumicha Wafula, while she was in studio here, said that they are hoping to raise, she gave us an estimate that at the moment NHF is collecting 44 billion shillings. I heard you quote a figure of about 60. And then that with the new plan, it's going to rise to 144 billion shillings. I heard her say that Kenyans spend out of pocket 150 billion shillings on medical care, but the total cost of the health sector is about 550 billion shillings. Yeah. Do you think that coming up with this fund, the contributions that will be made, the critical illnesses fund, but also the primary health care, do you think all those resources are sufficient to make sure that Kenyans do not have to pay a cent, or will still continue to pay despite contributing to the Social Health Insurance Fund?
Thank you very much, Sam. And normally before I come to a show like this, I normally get members' views, my members to give me a view. And probably one view that Citizen TV may need to take is that my members, they have said that Kenya, Dr. Wangari Nganga says that Kenya has 50% women and 75% of the people under 35. So probably Mheshimiwa here is the only under 35, and there are no women. So, but being a gynecologist, I suppose and young at heart, I will represent that constituency of women and those under 35. Adam Hassan Haji of Wajir is a doctor. He said, prioritizing costs over quality health care is counterproductive and very expensive in the long run. That's a very deep statement. And from Bui's area, Dr. Paul Musila, I think is the CC of Makueni, he said that policies require proper financing. Now I'll answer your question in that context. Yeah? So, and also to look at Mheshimiwa Mbui's other way of KK raiding pockets. I think with time, we roping in Mheshimiwa's collaborative way of doing things, I think we probably need to stop using such antagonistic language. And what we are saying is that that is the Kenya Kwanza way of trying to raise revenue. You see, it's not necessarily wrong, because taxation is one of the ways. But just to pose a challenge to Nelson here, I was in Catholic University of East Africa when prior to your team entering government, we gave presentations of how we want health to look like. I was actually the first speaker in that meeting, and I must congratulate them. They actually adopted probably 90% of our recommendations, hence where we have reached now with the bills, which we support. We support the bills with those caveats. You see, when we see that we need to cap it, we give that view. In terms of
I asked the question about
income, yes.
The costing.
Yeah.
Because like you say...
Universal health care coverage costing is a journey, which we have been in for a long time. And a lot of the things we are debating about is the methodology. You see, insurance is one model. You get, and it is the way that the government decided to take from the previous government an insurance model. That is okay. That is one way of raising funds. We, as Kenya Medical Association, had actually advocated for a tax-funded universal health care coverage, you see. And what does that mean? That means that, for instance, if you go from the top of the head and say 2% of VAT is allocated to health, that is tax funding. So the amount of money required to provide health should not be what is looked at first. We should look at what amount of money do we need in health. Then we look at how do we get this money to support health. There is taxation, there is government putting money into it, there is donor funding, there is, so that, and what of more importance, and I like Mheshimiwa Dan's, that person with a contribution of 500. I think you remember there was differential treatment. And because they were using an insurance model. And that's why the government has moved to a social health concept, whereby people don't get different qualities of healthcare according to how much they have contributed. And the example was the civil servants were getting higher because they were contributing more, and those who are contributing 500, there are even those who are not contributing to NHIF, so they were not getting care. We were doing out-of-pocket financing. So the direction the bills have taken is up. So what we need to do is, Mheshimiwa Nelson, organize a conference. Now that we know what health should be, how health should be conducted, organize an income generation conference. How do we get this money to fund healthcare? Instead of saying we only have 500, so we can only do your one knee, although both knees are, you get what I mean? So that is the problem. Kenya is having an income problem from many sectors, paying loans from outside. So let's fund health, and let's fund quality healthcare. And quality healthcare is expensive.
Tell me, so with the new plan, so if I choose to go to a private hospital, will I still be treated, or there will be different rates between public hospitals and private?
So again, that is the discussion that, and we tend to muddle up care by dividing patients into public patients, private patients. I think these categorizations we need to stop. What Mwananchi wants at the bottom is, I have this illness, I go to this facility, whether it's private, public, and when I come out of it, I get treatment. You see, so as a government, we need to ensure that this facility has quality care. And just to go back to the NHS, as quoted by, I think it was Nelson, indeed, there is a high taxation, in quotes, to the people funding healthcare. But again, the NHS is providing the quality care. So part of the issues that you are saying, you may, if you are taxed, then you can as well get the service. And just to give an overview, the NHS has about 250,000 doctors before we even go to any other cadres. You see. So they get services. So some of the other issues that need to be roped in are employment of human resources for health to be able to provide quality health care, even before the facilities are are given the key. You need people first.
Okay.
And this ropes into a bigger debate which the politicians and lawmakers need to address of unemployment. And the problem of unemployment again goes back to funding.
All right, Dr. Still, my question unanswered. Honorable Koch, I don't know if you have an answer. Because over time you've seen that, private versus public sometimes treated differently. Sometimes there's been this conversation that because these are resources, even when you're selecting an outpatient hospital, you find that there appears to be some silent preference for public facilities, and people making an argument that you need to invest in those public facilities because they serve a bigger population. So what is the argument here? Is it that once you contribute to the SHIF, you can go to whatever hospital? Bearing in mind that sometimes private hospitals are also more expensive than public.
The fear actually should have been, is generally in our minds. And I think Dr. should have been, will have been a very good person to explain that. You know why people fear private hospitals? It's number one, the fear of inflated bills. You just go for the same treatment. I mean, you'll find hospitals that are across the road of each other, the other one private, the other one in public. And these privates will charge almost 20 times more what is charged on a public hospital. Merely because, you know, they believe that they afford you comfort and a bit of a privacy, I don't know, and generally status that people believe in. No. But that should be reduced. And this I hope the social health SHIF is able to cure that.
How will it?
On emergency, it is on law. I mean, section Article 43(2) of the Constitution provides that no Kenyan should be denied emergency medical treatment. That is emergency. Now, this other one should be optional.
You know, Honorable Koech, that is in law, but remember the COVID season. You couldn't get admitted to some facilities without raising a certain minimum amount or deposit. It
was misconduct. It is, because there is no reason why during COVID you will have been denied to access medical care. But of course, it's private hospital and they also have their regulations and rules. So I believe that part of the things that we should do then in these regulations is to make sure that this card can be able to be used in any hospital, whether public or private.
So, Dan, I think the cost differentiation is clear.
Yep.
When a private hospital generally, let's put it like private for profit, generally cater for all their costs. When a patient goes, let me use as a gynecologist a cesarean section, you know, a patient going to a public hospital and a private hospital for a cesarean section where a baby is removed via surgery and you have the doctor there removing the surgery. The cost in the public hospital and the private hospital is the same. It's totally the same. But the role of a government, and hence the term public hospital, is to enable affordability. And the problem is that now the doctor who does the cesarean section in the private facility raises an invoice and is paid. The doctor in the public hospital also raises an invoice, but that is an invoice to the government, who have actually paid by employing him, you see. But that is not brought out. So we need to mix. So when the private hospital charges you, they are recovering their costs. The government has also recovered its cost through the exchequer. So the reason the person will pay less is because all those costs are not now being lumped on the patient. But ideally, if you are to charge that patient, and even we do it in costing, we've been that, the cost is the same. So I think there is the issue of inflated bills, let's say, but inflated is really a very vague term. For instance, and people go to private hospitals because maybe there is some care that is there. And I'll give you one example of a program you gave just now, endometriosis. I had the endometriosis story. Where in a public hospital will you have laparoscopic surgery for endometriosis, as was demonstrated in your clip? You get, the private hospitals have invested in laparoscopic machine. When I left Isiolo in 2013 actually recommended that the hospital should get what is called laparoscopy. Laparoscopy is minimal access, you know, access. It's not there in the public facility. So, and the standard of care is that. So when you go to a public hospital and you are charged, and it's expensive because the people who have trained, they have kept a lot of time, then we should now not say that it's more expensive. You see? So look at the quality of care. And maybe just to use the one last time, there's something called an ectopic pregnancy, which can be done laparoscopically or what is called open. You see, the benefits are more laparoscopy, but there is nowhere in a public hospital you'll go and get laparoscopy. But this patient who goes to the private goes. So now look at the quality of life for both clients and then use that as a measure. So let's avoid
that's okay, Daktari.
Argument.
And therefore the question, Honorable Madenge, have you had this conversation about how facilities are going to be treated, whether they are public or private?
Yes, the conversations are there. Currently, what you find is that private hospitals are not largely classified according to the levels of care under the health policy. Currently, a private clinic in Nyeri town offering outpatient services will have to be classified as either level 2 or level 3. The same way a dispensary or a health center in a public facility. And therefore, the package of care in all hospitals, be it public or private, at level 3, the package of care and the payments from NHIF will be uniform. Then we will go to level 4.
Regardless of this is a private facility, they're having to pay their own utility bills?
Yes. And this is the option that then Kenyans will have to exercise. The truth sum is, unless I have an emergency, and therefore the nearest hospital available to me is the health center in my village at Kihuyo, most likely I will rush to, as a person, I will rush to Mathari Mission Hospital or Outspan Hospital. That is an individual decision.
Okay.
But the level of care, the quality of care, the package of care for each facility in the same level nationally should be the same.
All right.
Are they the same currently? No. So there is a lot of capacity building and improvement that government has to do. And that is why you find that in the primary health care bill, the entire payments are tax funded.
All right. I hear you. Let's listen to a voice of the president while unveiling the Community Health Promoters Program in Kericho.
The work of the promoters will include basic preventive and promotive health, health education, basic first aid for the treatment of minor injuries and ailments at household level, and referral for facility-based health care. Each community health promoter is allocated 100 homes within their neighborhoods, and this will happen countrywide.
All right, and Honorable Mboye, so some counties have been maintaining community health volunteers, then they became community health workers, now they're becoming community health promoters, and there has been that conversation about their financing, 2,500 from the county, 2,500 from the national government, even though we know that some counties are paying more than that. In your view, what would be the impact of this, and connect that to the new law, facilities improvement financing, that now the facilities will be keeping the resources they collect? How will that work, especially for counties that previously have been digging into the resources coming from health facilities?
Yeah, thank you, Sam. Sam, first, allow me to raise a concern. I saw Daktari was concerned about the word when I said that KK is raiding our pockets, and he was a bit concerned about the language. Let me say that you know, sometimes the language you use is determined by the people that you are talking to. This is a regime that we did public participation and over 90% of the things that people said were ignored. So sometimes you end up there not because you want, but because you know who you're dealing with. And you see, you even talked about unemployment.
Yeah.
And one of the things that you've been told is that to solve the problem of unemployment in Kenya, everybody will go and build houses. So I think you need to teach your doctors how to build, because that looks like the direction now that this regime is taking. But then some, you know, there are different bills, and I'm happy we are moving on to the medical facilities improvement. First, let's start with the issue of community health, you know, promoters. This has been there. It's been around from the previous regime. The only problem that we are facing is that like in my county, Machakos, were being called volunteers. And so these people are working without any pay. And you know, if you do not motivate people, then it's unlikely that they'll be able to exert themselves. It's just like village managers. You know, village managers, those village elders, they work for the government. They're the lowest level of the administration. They don't get paid. There's a proposal now to pay them. So I think that one of the problems was that these people are expected to work without any pay. And the proposal to pay them, I think, is highly welcome, because then, therefore, they can be able to do this in a better way. And some, I do agree that it is better to prevent than to cure. It is even cheaper to prevent than to cure. So I think it's a very good idea. But we have an issue. I personally have an issue with the idea of ring fencing the money so that it remains at the hospital, at the health facility level. I think it's a brilliant idea. But the teams that are being formed to manage the money have actually not been given the autonomy to manage the money, Sam. Unfortunately, the money is still being managed by a central person, so that all the health facilities in a region still have to go to seek authority from an individual. We needed to release them to be able to carry out their mandate. Just like if you go to a school, there's a board of management. They receive the funds and they manage the school completely. They have the authority to incur expenditure on that money. Unfortunately, in this case, the authority to incur expenditure is not vested in the team that is managing maybe the health center or the dispensary. So that already creates another challenge, because the bottlenecks that will come up will mean that there will be delayed payments again. And you see, the reason this was being done was a brilliant idea. I mean, the idea was that you go to some health centers, you find the grass hasn't been cut. You know, mosquitoes are breeding there and even causing more malaria in the hospital because the grounds are unkempt. So the idea was a brilliant idea, that let them have money to spend so they don't have to wait for the county government to come and do it. Unfortunately, very good idea. Then at the end of the day, when you go into deliberations, you end up pointing out the biggest weakness of the proposal, and it is ignored. So unfortunately, we'll still have bottlenecks, so there will still be delays in money being released. Otherwise, it's a brilliant idea.
All right. And I want us to exit from this area. Let me give you the final word on it, Honorable Madenke, because then the law is quite clear, saying that the resources that facilities are able to collect does not mean that now the county is going to substitute. No, they will still continue to finance as they were. What are the risks, especially knowing that much of the 37 billion shillings that counties have been collecting as own source revenue, much of it comes from the health facilities, because there are some of the areas they collect revenues. How does that affect the management of a county, and how do they survive in the coming months and years?
Sam, thank you very much. I have worked in the county government. In the year 2013, 2014, 2015, 2016, I was the chief of staff in the late Governor Ruto Gachagwa's office in Nyeri County. I'll give you the perfect example. When we got what were known then as conditional grants for the former provincial hospitals, the decision of the Nyeri County executive at that time was that the entire health department in the county should first spend the conditional grant for PGH to run health services across the county, and then when that is exhausted, then the county budget would kick in. That was the decision then. I'll give you another example. Kakamega got the same conditional grant, but instead of running the Kakamega Provincial General Hospital, which was basically a regional hospital, Governor Oparanya decided to go and construct a new hospital, which to date is not complete.
Correct.
And therefore, the question of ring fencing, committing the funds for the purpose for which they were originally generated is good for all of us. This is accepted across the board, be it the politicians, be it the medics, and be it the community. But there is still the other question of how to ensure there is prudence in expenditure. And therefore, again, these are public resources, and we are guided by both the Public Procurement and Disposal Act and the Public Finance Management Act. At this point in time, those are the laws that guide how public money will be spent. Even as we have come up with the new system in the health sector, the financial sector and the procurement center largely has to comply with the relevant laws in that area. And therefore, we have had a marriage of convenience to achieve balance. Moving forward, today, is the Public Finance Management Act 2012 still fit for use for the things that we are needing to do today? Honorable Bui will accept, and he sits in some of the most powerful committees in terms of looking at how public expenditure is happening. So one of the reasons we asked ourselves, how does a dispensary account for money that is generated at that area? And therefore it was felt that it was important that an accountant is added to the structure for the purposes of accountability and compliance with the law. Is it 100% perfect? I don't think so. Okay. But we'll have to work with it and respond appropriately as we move along. The facility funds are not new. The cost-sharing funds, initially they were there as cost-sharing funds. And therefore, there are also lessons we've learned from the predecessor funds, and the gaps therein have attempted to be sealed.
So tell me, from your lesson of conditional grants to the level 5 hospitals, that once depleted, that's when the county government financing would kick in. The law talks about that the income and other receivables retained by the public health facilities shall be considered as a supplement to the budgets and resources appropriated by the public health facilities, by the respective county governments, and not a substitute. So is it that now the counties are going to create budgets with the facilities funds in mind, or is to create budgets based on need but leave them to also use these resources for their needs?
No. The county budget will have to budget as normally as today, without the facilities funds in mind. The only thing that will happen is that the facilities now, in the event of any shortages from the county budget, they have a kitty here readily available for them to seal the gaps. Those gaps could include development, which is not funded. A lot of health centers today should be providing maternity care. Very few of them are able to do that. A lot of health centers today should be doing simple diagnostics in the labs. And again, when you go to the laboratories, we have different classes. The county governments are unable to have all those present. And therefore, it allows the local community to decide, our priority this year is to set up a lab, and therefore, if the county government is not able to fund, we have our kitty from the facility improvement fund.
All right. I want us to listen to a voice here as we transition, because there has been this issue of demolitions that